Greetings and welcome to the Heywood Healthbeat. I'm Mike Ellis, your host, and I'm so pleased to have today Dr. Michael Mutchler. Dr. Mutchler is a practitioner at Cornerstone Family Medicine and specializes in family medicine and adolescent medicine right here in Gardner at the Medical Arts Building on Green Street. Dr. Mutchler, thank you for joining us. We really appreciate it.
Mike, it's a pleasure to be here and happy to be part of this conversation today.
You know, we had an opportunity to talk a little bit earlier about some of the interesting things you're doing at Cornerstone, and you have a very unique model of providing healthcare in Gardner and across the Commonwealth. Can you tell us a little bit about that model?
Absolutely. So I'm in practice with my wife, Dr. Michelle Parker, and we've been here in Gardner for the last 24 years. We've had our own practice of Cornerstone Family Medicine that we started in 2003, and we were working in a group practice with Dr. James Faust for the time before that. But 2 years ago, almost 2 years ago, we made the decision that we were going to convert our practice to direct primary care, largely based upon the values of what we have always felt to be important as physicians. We've always enjoyed the one-on-one interaction with patients and their families and getting to know them. And the way that healthcare has been proceeding, we started to feel a situation where we wanted to get a little more, I think, down to the nitty-gritty of how we want to deliver care. So this model of direct primary care has been out for several years, and the direct primary care practice is something that is growing in popularity. We have had a growing number of practices converting in Massachusetts, but also throughout the United States. And this really is, I think, an old school model of practice with modern day technology. We do not bill insurance. Sometimes people confuse us with concierge medicine, which is where a practice will bill insurance, but also have a somewhat exorbitant access fee to their physician for direct communication. But what direct primary care is where people will pay a membership fee, just like you would with a healthcare club, or I should say, a health club, to be able to work with their exercise equipment there. But for this, it's just to have 24/7 access to your provider, your physician. And so we offer the opportunity to have direct communication, so patients can call us directly, they can text us directly, they can send pictures to us, email us. It's just basically, it's me working for a patient versus me working for an insurance company that the patient will pay into. And so this model is really kind of getting to the core of why I went into medicine. It's an opportunity for me to, again, have longevity. I can go to the house with people, I can do video visits. And for me, it's just an opportunity to really find the joy of medicine, which was starting to kind of wonder where that joy is, but I've rediscovered it, and hopefully more physicians will be able to recognize and understand what this is. But for us, it was a decision we made, and so far, so good.
It's an interesting concept. It really is, especially in the day and age where insurance companies dictate so much about your care and what you're able to access and what they'll pay for or what has to be done ahead of time. So how are the fees set up? Is it a sliding scale? Did you mention that? Or is it a flat fee across the board for all patients?
So we basically have a different pay scale. We did actually decide that we were going to have opportunities for scholarships. So there are some folks that we felt that we would be able to help out who may have the need for some financial assistance. And so sometimes memberships, may be as little as $5 per month, based upon one's age or based upon if one is joining as a couple or if one is a student, whether it be a high school student or elementary school student or even a graduate student, we have payments for that too. So this, when you look at the payment scale, it for family, it's basically $100 per month. It doesn't matter if you're a family of 3 or a family of 10. If you're a couple, it's $80 a month, so basically $40 each. An individual up into the age of 65 or so is $60 a month. Its age after that it's $40 a month. If you live to 100, it's free. And so I do have one of my patients who's going to be 105, and it's my pleasure taking care of her. And so that's the goal to get to.
How cool is that? That is really kind of neat. It's an interesting approach to healthcare, and I applaud you for doing that. You've been in medicine for over 30 years in family medicine and adolescent medicine, and over 25 here in the greater Gardner area, which is remarkable, by the way. And tell me, how has things changed in family medicine from when you first started practicing to today? What are some of the big changes?
Well, I'm going to say that for me personally, when I first started out in my career, and I'll give you a little background, is that my wife and I both met and we trained at UCLA. So in Los Angeles, we got a very robust education in taking care of people from the time of birth to death. Obstetrics is something that we did for many years. We had such an interest in that we decided to do a fellowship in rural family medicine up in Tacoma, Washington, where we did 6 months of high-risk obstetrics, learned how to do cesarean sections and other procedures. And that prepared us for our next venture, which was a 2-year stint on the Navajo Indian Reservation in Shiprock, New Mexico.
Huh.
And so being there really was an opportunity to expand just the level of practice that we did. We work in emergency rooms. We oftentimes were the only physician in the hospital and being prepared for anything that would be coming through. And so our background is one where we were doing quite a bit. And when we first came to Gardner, we were doing hospital care, including ICU care, delivering babies, having an office. And what has changed, I think, in medicine is the fact that outpatient care has become very robust and busy. And so one thing that has happened here locally, which has throughout the country, is that we have now hospitalists that oftentimes are going to be looking after our patients when they're in the hospital. That has been a big change. My wife and I, through a decision that was really guided by the fact that she's a breast cancer survivor from a few years ago, but her oncologist encouraged us to think about scaling back on the interruptions during the night to keep her well. So we had to give up obstetrics. It was a very hard decision, but the nice thing about that is we still get to have newborns in our practice and continue to care for them. And so, so I think for family medicine, it really is, you can make it what you want. And, but I think the biggest thing is just in terms of hospital presence throughout the nation and here. It's helpful, though, that when our patients are in the hospital, we can certainly, where we're located, go right over and do social rounds with them so they know we're on board. Certainly available to speak with the hospitalists about anything involving them, helping any family decisions. And so for us, it's a nice situation.
You mentioned that you did some work not oncology, on obstetrics. So learning how to do some of those very precarious sometimes procedures on folks who are giving birth. And that specialty is very unique and it's a well-known specialty, although it's really, if I understand it right, it's grouped under family medicine. Tell us what is family medicine? Why is there a practice called family medicine as opposed to a specialty?
So family medicine actually is a specialty. It's actually the offshoot of what was called general practice. And general practice used to be that you would do a 1-year internship and then go into practice. But family medicine is an offshoot of that. And basically it's a 3-year residency. It's a specialty that encompasses care of an individual and family throughout the entire lifespan. So we are a specialty of breadth, not necessarily depth like some of the super specialties are. But we should be able to handle perhaps 85 to 90% of what comes into our office. And based upon how involved you want to be with your patient in terms of working them up or what your level of comfort is, it's an opportunity for you to be able to do that. And we also think that as a niche of family medicine, one of the best things that we've noticed here being in Gardner is the fact that we can take care of multiple generations of families. And so I've had the opportunity and pleasure of taking care of a couple of families where I basically was 5 generations, which was really kind of an awesome and unique opportunity. So our decision to come here to Gardner was based upon just the community itself. Family medicine has been embraced through the years. And so we have family medicine as a way for people to get their primary care. It's a specialty of longevity if you want to certainly grow old with your folks here and so to kind of see them through their lifespan. And so that's why we have that.
I just learned something new. I did not know that family medicine is a specialty per se. I always thought that general practice and family medicine were the same, that they were symbiotic, but there's obviously some differences. So thank you for sharing that.
Yep. General practice is what we used to have, and now we are the offshoot of that.
So what are some of the biggest challenges for you or for new graduates, coming out of medical school that may prevent them or hinder them from choosing either general practice or family medicine as a specialty, and opt to go into, say, one of the more lucrative. What are some of the challenges you faced over your course of practicing?
Well, I think the first thing that you have to realize that if you go into family medicine, you have to be very comfortable with the concept of uncertainty. Because when someone is coming into you with a various variety of issues, you need to you need to recognize the fact that there will be some uncertainty when you're going to be working them up, and that's okay. I think that once you have experience and we know the ability to kind of take care of them and to try to make that uncertainty out of certainty, then it'll become a little more comfortable for you. But I think as a new grad, because we are a specialty of breadth, again, it's the fact that you are given a basis to learn, but this is continual learning. And particularly when you're dealing with people of all ages, things are changing. And when you're dealing with dabbling into heart aspects or lung aspects or the whole body, which is what we deal with, you need to stay on top of all of that. So a lot of what we do is counseling and psychiatric work, and really it is taking care of the whole person. So I think just the knowledge that one needs and the comfort in that is, I think, some of the biggest challenges. I do know that this is a calling. And if you want to look for a lucrative position in medicine, you're not necessarily going to find it in family medicine, but that's okay, because we talk about the psychological paycheck, which is you're getting satisfaction and rewarded in ways that don't necessarily have to be a monetary value, but it's what makes you get up and come to work every day.
I imagine those psychological value added is immense sometimes as you're working with a very diverse population. You mentioned behavioral health and mental health, and one thing that I've observed, and again, I may be wrong, but I've observed that mental health and behavioral health really wasn't a focus of docs as to the degree that it is today. How much have behavioral health and mental health concerns or issues changed the way you practice?
Well, I'm going to say that I've always had an interest in people, and I've always had an interest in how people feel. In fact, there was a time in my medical school that I had thought about whether I actually wanted to go into psychiatry, and then I realized, what, as a family physician, I'm going to be having a lot of psychiatry that comes my way, and I've always been interested in being able to speak with people to try to help them get to the basis for how they feel. And I think because of my interest in helping people with their mental and emotional health, I've taken a great interest in, again, pursuing education and how to do that. So I feel very comfortable in that realm. I know my limitations. I think that's the other thing, that as a family physician, you need to know your limitations and understand them. And that's perfectly fine, because, again, as a specialty breadth, you're going to have that. But I'm going to tell you that it varies from person to person, from physician to physician, but I and my wife as well, we do take a great interest in the psychiatric and health of our patients, and so we're very involved and continue to be very involved.
I think that's an important message for our listeners and watchers to hear, that no matter what the ailment, whatever the issue or condition is that you may be experiencing, whether it's a physical ailment or pain or problem, or a psychological or mental health one, it's important to bring those up to your doc, because it's a holistic approach to taking care of the patient. So something that may be happening psychologically could be really an effect of a physical condition, and vice versa. The pains and aches might be a manifestation of a mental health issue.
You're absolutely right about that, and that's where I think that longevity and knowing your patients comes in very handy. Also, knowing the family situation is very important too. And so you're right; the mind and body are very closely connected, and you have to be thinking about those possibilities and how a physical illness may manifest itself as a worsening emotional or psychiatric situation, and vice versa. We know that certainly when people are hospitalized, you're going to certainly expect that there's going to be an emotional response to that, and be prepared to help somebody through that. And so I think it just means having the opportunity to be able to do that. And I will say this: one of the challenges in family medicine in a non-direct primary care situation is the amount of time that one can spend. There is a situation that has been occurring that you don't really get to spend a whole lot of time, in many cases, with your patient. You have to kind of move on to the next. But in direct primary care, we actually have the opportunity to have extended visits. Some of our visits are a half hour, some are an hour, It's not rushed. It's the opportunity to talk and dialogue, which really does help, I think, for me, in really ultimately taking care of patients.
Yeah, I agree that communication, that dialogue is essential to, really being able to pinpoint what the problem is, or at least start down the right path to find it. So I really applaud and admire our docs that are in family practice. Not that I don't admire those that are in specialty care and providing exceptional service in obstetrics or orthopedics or cardiology. They do a wonderful job, but I think there's this real you can relate to a family practitioner, and they seem to be more relatable because they're dealing with you every day, not just that one problem, ache or pain.
Yeah,
So
and we have certainly many well-qualified practitioners, our nurse practitioners and physician assistants and providers in family medicine. I think you go into this if you want to be able to work with people, talk with people, and that's, I think, why this specialty is one where people, I think, when you're hooked on with a good communication with your doc or with your other healthcare provider as an NP or PA, it really can be helpful for your overall health.
I'm going to ride that horse for a minute because I want to remind folks that one of the most important relationships you can have is with your doc, whatever that doc is, whether they're, focusing on a cardio issue or they're your family medicine doc. Those, people are the most critical people in the kind of continuation of a healthy and successful, life. So, get comfortable with talking about the uncomfortable things. It's really what drives the decisions and ultimately the best care that we can get in our community. Now, speaking of best care in the community, you've served on our medical ethics committee at Heywood Hospital as the chair for some time. You're still the chair now, I understand.
Yes, I've been on the committee for the time that I've been here for over 24 years, and I've been the chair of that committee for many of those years.
Wow, that's exceptional. Again, a great a great strength and skill to be added to your repertoire. What is medical ethics? I mean, why would we be worried about medical ethics at Heywood Hospital or any healthcare system?
Well, the issue with medical ethics is the fact that when it comes to healthcare and healthcare decisions and what's taking place, there are many scenarios that can be very challenging and very difficult in taking care of people. And so the value of medical ethics really is an opportunity to look at what are some of those conflicts that may be present and what are those issues that may be present and come to a decision or conclusion of how to approach something in the best possible way. So we talk about values, and there are some key values in medical ethics that are time honored. And the very first one is autonomy. And autonomy is the principle by which a patient has the ability to kind of guide their healthcare and their healthcare decision. That's a very, very important principle. In other words, if I have a patient in my office and I say, here's the situation, these are some options, and the patient may say, thank you very much for your concern, but I'm going to go ahead and proceed in this fashion. And you have to certainly think, as long as they're informed, they have that right to guide their destiny. They also have really the principle of non-maleficence, which is doing no harm. So I took an oath to do no harm. And so you want to make sure that whenever you're taking care of somebody, that you're not providing any harm. And then you have beneficence, which is the principle of providing benefit to a patient. You also have the principle of confidentiality, which means that certainly when you're taking care of somebody, you have to recognize and respect the confidential nature of your discussions. There is a principle of veracity, which is truth telling. There is the principle of distributive justice, which I think becomes increasingly more important in the economics of healthcare, to say is, do we only have a certain number of resources, and how are we going to allocate them in a fair way? In other words, we don't want to necessarily have someone spend all this money on something that's going to be futile, but how can we try to, as a system, allocate them in a very fair manner, regardless of who you are, based whether it be ancestry, gender, age, things of this nature. And then there's other principles, paternalism, which is the old-fashioned way, which is docs would say, hey, you're going to do it my way, or you're not going to come here anymore. And that really is something which we don't really advocate for any further. So it's important that when you're faced with a situation clinically, whether it be as an outpatient or inpatient, that you recognize that there's going to be some conflicts that arise, and how can you go approach those conflicts in a way that's going to, find a way that's going to be, an ethically sound way to approach things.
You mentioned so many aspects of medical ethics, really kind of addressing racial disparities and autonomy, which is huge. I don't think a lot of people really understand the importance that that value is placed by practitioners, clinicians across, across the board. And that we have a group that's committed to and dedicated to ensuring that those values are steadfast and held in the highest regard by the folks that practice at Heywood Hospital and Heywood Healthcare. And it's exceptional that we do that. I had, for the first time, really dived into medical ethics when we first talked about getting together and looking at what that means. And that includes things like patient rights. And you talked about autonomy and the ability to make decisions on your own, but the whole scope of patient rights and equity of resources. As a patient, I would never think about, those kinds of considerations, but they're addressed on a regular basis in our medical ethics committee. And I think that people really ought to feel good about that. They ought to feel good about the fact that our docs come together and for specifically the purpose of ensuring that these time-honored values are upheld and maintained in providing healthcare.
Well, I'm going to say too, it's going to be an increasingly important thing to be thinking about here, that during the times of the pandemic, and as we're seeing in parts of the country, parts of the world, and what we were preparing for in the spring and now be preparing for further, is if you fill up institutions and hospitals with people who are sick and people who are very sick, there's only a limited amount of resources. There's only a limited amount of intensive care unit beds, a limited amount of ventilators. And unfortunately is that we are faced with the possibility that if we ever come to a point where we don't have any more availability in the state or region to take care of people, that's where ethics comes in. It's basically public health ethics, where you need to be thinking about how do you ethically allocate those resources to individuals. That's a very, very painful decision to have to make, but it's a very real one. And so we do have a system in place at Heywood that we put in place in the spring and we'll certainly have available. We hope it doesn't get to that point, but every institution should have that present in the event that something like this happens.
Yeah. And who would have ever thought we would have been in a place like we're in, today with the pandemic raging across the country and the world. And it's nice to know that there's, again, a group of folks that have this standard of behavior, rules, and mores, values, that they are really using as the foundation, the springboard, to talk about things like, if we need to, how do we address wide-scale service and treatment of patients in this kind of a situation. So to me, that's very kind of comforting.
Yep, and we certainly we put a lot of work into that in the spring, and we do have a lot of individuals who are going to be part of that throughout the Heywood community in different levels to make that happen. We hope it doesn't get to that, but we certainly, if we need to, we will be prepared for that.
Yeah, we're all hoping it doesn't get to that. Hopefully that people have enough reassurance on what are the the right things to do to prevent that from happening. So I'm with you on that one, and definitely in your court. One of the other interesting things that have happened as a result of COVID is the use of social media. How much has social media been part of your discussions as you talk about medical ethics?
Well, we know that certainly there's a lot that's out there. In the internet, there's a lot of information in terms of social media. I think it's important for people to be able to have a trusted source of information and to be able to recognize and to know where that is. And that's why I do think that as healthcare providers, we are certainly going to be aware of what is going to be reputable information. So I think when it comes to ethics, part of ethics is also having the right information available, having updated information which is available when it comes to medical decision making. You want to make absolutely certain that what you're telling somebody or advising somebody is accurate, that's appropriate, and peer reviewed. And so you have to kind of filter out some of the stuff which is there that you'll see that's misinformation. Educate patients that may think that they read something which is actually true, but it's not. And so social media, it really does, it's challenging to try to guide what's best to be thinking about best ways to deal with it. But, people are sometimes also going to decide for themselves what they want to believe. And that's, I think, an ongoing discussion that you have to have with people.
WebMD has become a real resource. And sometimes I guess, maybe it's a little bit of a barrier to providing the care that you want to provide. But like you said, people get to make the decisions that they feel are appropriate for themselves or their family. We're going to go into a new topic, but we're going to segue that with the last issue of medical ethics, which is confidentiality. And I think confidentiality has really gotten a lot of focus, certainly since HIPAA. Why such a big deal? I mean, why are we putting so much emphasis and time and resources into confidentiality?
Well, I think that when we are confidential, you want to know that people can feel that their information is safe and protected. There is information they may have in their own medical history that they don't want to get out because it actually could potentially be used against them. It also, you want to try to take away from the stigma of anything that might come about if someone has a certain medical condition that is certainly very normal and appropriately treated. But if word gets out, then again, that could certainly cause some very difficult situations. I'm thinking about the fact that, as we talk about pandemics, of how we used to be able to mark off on houses who was under quarantine. And so you'd be driving around town, you could certainly see these X's on houses and know that the Jones family was under quarantine or the Smith family down the road. And we've changed our stance on that. And I do think that it's a real out of respect for one's own personal information. Again, we want to make sure that people know that they're safe and that their information is going to be protected. So I think it's a very important that we should certainly honor.
And I think anybody who's questioned that should know exactly what you said, that there are biases in our community. People hold biases, even though they're unfounded sometimes, many times, oftentimes, most times, but they do exist. And so holding that information as close to the best as possible is not only practical, but it's vital to their survival and their ability to be able to get good jobs or to send their kids to schools or things like that. So it's absolutely essential. And thank you for underscoring that. And so with that, I'm going to go into some documents that folks need when they're hospitalized or providing healthcare. And one of those is a HIPAA authorization. So we just talked about privacy and the fact that you can't share information, just offhandedly. Let's talk about some of these documentation requirements, necessities that people need when going into the hospital, and start with the HIPAA authorization. What is it and why do they need it?
Well, basically, again, it's you have protected health information, and so it just means the fact that if you're in the hospital, you may have people who are calling, concerned, wondering what's going on, and the patient has to have the ability to be able to streamline that information and to say who can call, who is okay for them to speak with. Again, that is just to kind of make it a controlled situation. Because if you just allow anybody to call and word gets out, that can sometimes morph into something which is actually not very true, and again, could be injurious to the patient. So you want to make sure that information is really only applicable, the information in terms of who needs to know it. And who needs to know it would be the treating physicians, and if the patient indicates someone that they are very close with and want them to know that, they'll know that information too.
Yeah, and that's important because I think patients need to understand that. But for having that HIPAA authorization, healthcare providers generally can't. I mean, there are some exceptions in public safety, the health and risk of safety to themselves or others. Information can be shared on a very tight and strict basis. But if they want their loved one, they want their children, or they want their friend, their lifelong friend, to have access to that information, they need to give authorization. Otherwise, the healthcare providers will follow very strictly the law and not release that information, sometimes to the detriment of the patient. What other kinds of documents should folks look into or negotiate or execute before going into the hospital?
Yeah, well, I think we even segue in terms of even before the hospital, and this is a nice segue into what we oftentimes will do in medical ethics, and that's talking about how should we frame the idea that we know that illness and injury can happen at any time, and we need to be prepared for that possibility. And I think that when it comes to how we would want to be cared for, it's important for everyone who is 18 and over to designate a healthcare agent. And in Massachusetts, we have what's called a healthcare proxy.
I'm going to interrupt you, Doc. I apologize, Dr. Mutchler. Just say that part again, because I think just like with wills, people don't think they need a will till they're on their deathbed, but we know that circumstances can arise. So just say that one piece again.
I'm going to share it again. We know that accidents and injuries can happen and illnesses at any time when we least expect it. And so it's important for us to be able to be thinking about that and how we'd want to be treated in that circumstance. And so for adults in Massachusetts, we have, if you're 18 and over, we do recommend that you fill out what's called a healthcare proxy, which is actually a legal document. You can do it on your own, or you can do it with the help of a lawyer. But really what that does is it names a healthcare agent who could speak on your behalf if you were incapacitated. Now, this is part of one of two types of advance directives that we have in this country. And Massachusetts is one of a handful of states that has a healthcare proxy. In other states, the majority of states, they have what's called a living will. A living will is basically something that is a personal statement about how you'd want to have your healthcare proceed if you could not voice that. And so in Massachusetts, that type of thing in terms of a living will can give information about your values. It's not a legal document in Massachusetts, but it's something that can go along with information about what you would want. So again, having a proxy, you can name your initial healthcare agent. You can have an alternative. Sometimes people say, they refer back and forth that a healthcare proxy is your agent and vice versa, but that's just naming somebody. It's different from a durable power of attorney, which is someone who, it's a situation where it's a legal document where you can appoint a financial decision maker if you can't do that. That's very different from a healthcare proxy. So the other things that we want to make sure that we're thinking about here is if in the event that let's say we're out and about and we have some type of issue where we become unresponsive, we have some kind of heart or lung issue that renders us not having a pulse or not breathing, would we want to have opportunities for life-saving measures? And that's what we call a DNR, a do not resuscitate order. And we have in Massachusetts what's called a MOLS form. It is a form that is two-sided, and it stands for the Massachusetts Medical Orders for Life-Sustaining Treatment. This has replaced what was the former just DNR form, whether we want to have that resuscitation or not. And this MOLS form it's a completely voluntary document. It's an order that if you're out of the hospital and if you have this filled out, it'll give some directives in terms of how you want things to proceed. And so oftentimes when I'm counseling patients about this, I say, and what are your thoughts? What if you were at a point where you're, let's say, in a parking lot and down you went and someone went up and said, this person is not breathing or doesn't have a pulse. What would you want? Would you want to have an effort at life-sustaining or life-supporting measures or not? And so we have basic life support and advanced cardiac life support. And sometimes people reach a point in life where they say, if I don't have a pulse, I'm not breathing, don't. But many people say yes. And so these are opportunities, this MOLS form, to kind of identify what you would want. And there's another part to this MOLS form, which is if in the situation you were hospitalized, would you want to have certain types of treatments? For instance, would you ever want to be put on a ventilator? Would you ever want to have artificial nutrition? Would you ever want to be artificially hydrated? Would you ever want to have dialysis? Things of this nature. And so this is something that I think it's important for us to be thinking about at any time in our life. You're never too young to be thinking about this. It's even, I think, okay to talk about it with teens. And there's actually opportunities that when children get sick too, when children get childhood illnesses or cancers, there's opportunities for them to kind of be thinking about stuff and have that discussion. Because I always tell people, and I always ask my patients, what's the most common cause of death? And they say, gosh, I don't know, maybe it's heart, whatever, it's birth. The most common cause of death is birth. And so we are, birth is something which is very natural, and death is, and eventually we're all going to be coming to a time where we're not going to be living anymore. So we want to be kind of thinking about as an advancement of how we want to live our life, and when things got to a point where we get sick or injured, or at the end of our life, what do we want to have happen? And so it's important for communication. And it's very interesting is in November, we talk a lot about having opportunities for discussion. And traditionally, it's been felt that maybe a Thanksgiving gathering might be a nice opportunity to kind of talk about one's wishes and desires. And obviously, this type of Thanksgiving is going to be different, but obviously for those who like to do things virtually, you can do that. But it's just a chance for people to engage in certain discussions. And sometimes it's a very, very hard topic to bring up. It may be difficult for one who wants to talk with their family about this to be able to figure out the right time. It may be something that maybe someone doesn't want to talk about it, and maybe the family does. And so I think that there's different segues to be able to engage in conversation with it, and again, to try to normalize it. So when it comes to deciding who your healthcare agent is going to be, in ethics, we deal a lot with this. And we talk about those healthcare agents who are good and those who are not good. And you want to have a healthcare agent who you pick as being someone who's going to honor what your wishes are. If you have a healthcare proxy or designate who says, yeah, I know that this patient said this, but here's how we're going to do it, that's not a good proxy because you're not honoring what one would want. So you want to have someone who you can trust. You want to have someone who can voice for you, and someone who, when you cannot make those decisions or make to the capacity to kind of voice for yourself, let them to kind of be there to help guide in that way. Now, a healthcare agent can be anybody who you want. It doesn't necessarily have to be a spouse. It doesn't necessarily have to be a parent or a friend. It can be someone who you actually trust in the way that you want. And so sometimes that can be an interesting discussion to figure out who is my agent and why. And sometimes people may feel a little upset or feel like this person didn't want me.
Yeah.
There's a way to have an alternative proxy on there too, and that's if the first one can't do it. But again, that's part of the communication with it. And I think that the earlier communicate, have it in a relaxed fashion, I think the better it's going to be for everybody. Because if you can then talk with what your values are going to be, because sometimes proxies are like, yeah, I was put in this position, but didn't know what they wanted. So you only have to be able to voice what you want with them, so they can honor that. And so that's where you come into a values history in terms of what are your values, what's important to you. Is it important to you that you want to be out of pain? Where do you want to be in certain circumstances when you're receiving your health care? What's important to me in terms of what I enjoy in life? And this values history is, I think, very important for us to be thinking about and having those discussions.
You really brought a much different perspective to this conversation than I initially started with, because I always have thought and felt, even though I felt firmly that people should have wills early on in life when they're healthy and get those things established, I always thought the medical documentation was something that you waited for until you were going into the hospital or there was some life-saving or life-threatening condition. And you really helped clarify the fact that no, that these documents should be done ahead of that, hopefully well ahead of that, so that you're not stuck in a situation where now somebody has to be making a decision and not know, what your wishes are. So thank you for clarifying that.
I also want to say, too, that sometimes people change their minds, and certainly with the MOLST form, it's okay. You can rip it up and be void, and you can change that. It's the same thing, too, with a proxy. You can decide if you want to have someone different. So nothing means that once you've said it, that it's going to be like that forever. You can change minds on things, and sometimes people do. And that's okay, because we may have thought something at a certain point in our life, and then as it gets closer, or as a new situation comes up, we have the ability to change our mind based upon decision making. That's again where you said having a good relationship with a provider to be able to kind of go through and be part of the decision making. It's very, very important to have that relationship to kind of be able to guide through what's important to me. Do I want to have this treatment? Does it mean I'm going to have this treatment? I might feel terrible having it, but it might extend my life. Or is it, look, what's important for me is how I feel. Maybe I just want to feel okay and know that I might not have that extra time. So these are things that you have to be thinking about, because sometimes you can't have quality and quantity together. So these are kind of nuanced discussions.
They really are. And I want to just reiterate one thing that you said about the difference between the durable power of attorney and the healthcare proxy. The healthcare proxy is responsible for and has the ability to make decisions on your behalf as it relates to medical issues, but not necessarily on your behalf for those financial or state issues. That's your durable power of attorney, and vice versa. That if you have a healthcare proxy, the durable power of attorney can't override or overrule what your healthcare proxy is suggesting or recommending or deciding.
And the healthcare agent really goes into effect when the patient at hand does not have the capacity to make those decisions, which is very different from competence. Competence is a legal or court based decision. Capacity is really a physician can decide this person does not have the capacity to be able to understand what's happening, or in the case of someone who's unconscious, they obviously can't be speaking about
Right.
what's happening at the time. So that's, I think, a difference to understand as well.
So folks, you've just heard from Dr. Michael Mutchler. He's a family medicine and adolescent medicine practitioner at Heywood Hospital, Cornerstone's Family Medicine. He has been just an unbelievable resource to me, and I think you heard a little bit today about why he's so well regarded and respected in our community. Serving on the medical ethics committee at Heywood Hospital, you've been remarkable today in providing great information about things like the documents, the healthcare proxy, the durable power of attorney, the MOLST form, which is the first time I heard about it was today before our session. So remarkable information that is practical at any time. You don't have to wait till you're in a devastating catastrophic illness or injury to execute those. Dr. Mutchler, thank you so much for taking the time to be with us today. We really appreciate your guest appearance here on the Heywood Healthbeat and hope to have you back soon.
Mike, I want to thank you again for this opportunity. I'll speak for my wife and I. It's been an absolute pleasure being here in Gardner at the Heywood community, and we certainly hope, if God willing, I'll say that we can do this for many, many years ahead. So thank you very much.
Hoping that for you as well. Ladies and gentlemen, this has been the Heywood Healthbeat.